So I think we'll start with Mohan sir. First question, sir, in your scenario, is digoxin making a comeback? Recently I saw some European journal, they said in your scenario digoxin could be useful at much lower doses.
Digoxin, it is blood pressure neutral. Actually, the newer data has come with digitoxin. It's a little different from digoxin. We don't have its availability. But generally, it may not improve the mortality, but repeat hospitalization can be lessened with digoxin. So, especially so with if person has an atrial fibrillation, all the more reasons to start it.
But the dose is lower than what we
Always
use.
half the dose, 0.25 milligram, half tablet is preferable.
How do you go about a patient who is wet or cold, when like acute scenario, when the BP is 90 maintained on pressors? Is there any timeline, or how do you go about treating those patients? Sir?
These suggestions from the ESC HFA has detailed us how to manage in the acute setting. So at least 24 to 48 hours, you have to be guarded on the use of beta blockers or ARNI. But MRA and SGLT2 can be attempted once you are hemodynamically stable. Otherwise, I think if it is an acute situation less than 80, I think everything is no except for your diuretics and inotropes and other measures. Or if available a mechanical support. These are the standard dictums of an acute heart failure situation. But once 48 years were over, then bring in all the initially with the GLT2 and an MRA and then beta blockers and that can be achieved possibly, as we have seen in the strong heart failure data. Most of the time we can do it in 2 weeks.
Ivabradine has role?
Again, ivabradine is something. Even it is mentioned that it can improve the blood pressure, unlike beta blocker. But generally, we combine, use it in association with beta blocker. But as you said, if the blood pressure is a pressing problem, definitely ivabradine can be used.
To our second speaker, the heart failure with the preserved ejection fraction. In very obese patients, it's written that sometimes this NT-proBNP can be falsely low. So, how we should assess the NT-proBNP in very obese patients?
That is a fact. In obese patients, the BNP levels are low even if they have a heart failure. That's called the obesity paradox. So, still lower cutoffs are mentioned for obese patients, and there are certain corrective formulas. It's too complicated a mathematical formula, but they are available depending on the weight of the patient to calculate how much we can take as a cutoff. But no definite guidelines have been laid down.
Does treatment of OSA benefits, sir, in this?
Definitely, because it is a complex, it is a group of metabolic problems actually. Nowadays we think this it's a part of a metabolic syndrome itself, this HFpEF. So OSA treatment definitely will lead to improvement of that.
How good is it, because this is the particular patient you said that all the scores are intermediate. So will you recommend a diuretic challenge? Because to see whether the breathlessness improves, you try a diuretic, and maybe if that improves, probably we know that for sure that it is heart failure with preserved ejection fraction.
I did both the scoring systems in her. In one she was intermediate, one she was in heart failure with preserved ejection fraction. So we need not go for the invasive mode of measurements, because already we are almost sure that she is in a heart failure with preserved ejection fraction. And as sir said, a diuretic challenge is very useful. If she improves, we know that this is heart failure. If it doesn't improve, it could be partly due to her obesity, partly due to her deconditioning. So for practical purposes, once you do the scoring system and you find that it is towards the higher side, try a diuretic challenge.
I agree. Most of our patients with obesity and who complains to our OP with breathlessness, they are branded as obesity-related breathlessness, and we don't give them opportunity to treat them. Leave alone when the markers are all borderline. And in one of the FF trial, when they tried to add the NT-proBNP, it did not add any value to that. So maybe if there are some lot of clinical common sense is important when we are treating and recognizing heart failure with preserved ejection fraction.
It's actually a mixture of all this. So
Right.
weight loss plus diuretic, they will
Right,
be
right,
benefit.
thank you.
Just one question related to that. Patients with HFpEF, when they develop intercurrent infection like pneumonia, they develop AF, they go in for HFrEF, right? Then you add diuretics, and they sometimes revert back to HFpEF. So we'll off the diuretics, right? We'll keep whatever the HFpEF standard treatment, right? That is the. Do you?
Yeah, that is quite agreeable. Diuretics are only to relieve the symptoms, to relieve the congestion. It has nothing to do with the basic disease process. That's why the 4 pillars I showed, they include only SGLT2, GLP-1 agonist, phenernon, and lastly ARNI in a small subset. Diuretics are to be used SOS. Now people even think that there is a ADHF, acute decompensated heart failure, with preserved ejection fraction coming up. As you said, any intercurrent illness, atrial fibrillation worsens the symptomatic status.
Next to GEEVAR, sir. In our scenario, usually after post-BCA or any ASCVD events, patient used to go back to their smoking habits. So the nicotine patch is available, but I seldom seen physicians and cardiologists prescribing nicotine patch. That effect is up to 16 hours per day. Nicotine, the basic nicotine replacement therapy, NRT. So 2023 guidelines, European guidelines says we should promote NRT with behavioral modification. But that portion, even though if they are coming with smoking again, we are not at all advising that much. What may be the reason?
I agree. That area I did not elaborate because all the 5 A's of smoking cessation. The problem now, I think I didn't. What is the experience of other cardiologists also? But there are very few percentage of my patients are smoking, continues to smoke now. I think smoking generally has come down in Kerala significantly, and in most of my patients, maybe only less than 5% continues to smoke. So I agree with your point that cardiologists, we have been a bit negligent, but even this 5%, the simple 5 A's, and I have a protocol. I have been successful in setting up without the nicotine replacement therapy. Without that, I give them the quit date method, quit date method. Because normally everything, if you want to do something, you need to prepare your mind. So you say, I will tell them, you set a date for 15 days ahead, and then give publicity to that date to all your friends. Tell 100 people that you are going to stop smoking 15 days after this particular day. And then my success rate has been around 50% smoking. So nicotine replacement therapy also we are using. I think cardiologists are also using that. But the need for that has come down markedly.
Experienced with Varnaclin. Varnaclin, though it is difficult to get and expensive, but there were instances where we were contemplating apart from the detoxification with nicotine.
I am Dr. Sajith from Kodungalur. One aspect which I need more clarification is regarding the iron deficiency status. Especially, I would like comment from Dr. Karunadas. In heart failure management, this iron status is considered. Is there any difference in approach when we are treating HFpEF and HFrEF regarding the iron status? In general, iron status needs to be more taken into consideration, I think, especially in the setting of shortness of breath and all.
There is validated data in reduced ejection fraction that you should look at the iron stores. not the hemoglobin, but the iron content and the iron stores of the body, and replenish that. And definitely it produces improvement. And it's come as a class 2A recommendation nowadays in reduced ejection fraction. But in HFpEF, probably it should be useful, but no such data has come. It should be useful, just like reduced ejection fraction.
Thanks.
If there is anemia, it will be useful.
Anemia definitely useful, but in a reduced ejection fraction, even when the hemoglobin is normal, you are supposed to look at the iron stores and correct.
Because iron deficiency is much more rampant. Once
That's
we
correct.
start looking for it, it's hugely rampant. So that needs to be taken care of, I think.
Sure.
If we don't have any more questions, I think we will conclude. Thank you to the speakers and the excellent question and answer session. Thank you. Thank you.